So what I want to present, so this morning and this afternoon, we've heard a lot about the AI developers, the clinicians, the industry perspective on how they're using AI. And they're doing lots of wonderful things, lots of wonderful things to help making diagnosis better, making prognosis better, making better treatment plans, in the hope to making our lives as patients better. But I want to switch that. I want to switch the conversation to about patients that have lived experience of those diseases that we've been talking about, and looking from their perspective. So my name's Anwar, and I was that person that reached out to Richard around, pre-COVID days, many years ago, around some help around the genomics program. And I have with me there Tony Thorborn, who's our lead, if you will. We have the co-leads in what is a mouthful of an acronym, which is the Genomics AI Network of Excellence. I'll abbreviate that to GAIN. Yeah. And I've got a lot of slides, but I'm not going to go through them in the interest of time, because I want to get to our panel discussion, because you've got a great panel here. I want to get the most out of it. I'm sure you didn't come here to listen to me. So I'll just abbreviate a lot of the slides I did, which took me more than 5 minutes. That's James. It took me a lot more than 5 minutes. So the context what we're doing is that NHSE, through accelerating their genomics program, put together funding around 15 million to try and evidence new technologies, new methodologies that we could adopt at a system-wide scale. And they wanted to bring in a collaboration of industry partners, academic partners, NHS institutions, and patient groups as well, in terms of developing those frameworks. And of those 8 networks that were set up, we're part of the Genomics AI network, and we are, that's okay. And we are based in, if you like, southeast London and Kent, Surrey and Sussex, and that central spine running down Southampton, Oxford and Birmingham. And the point of that slide is, if you want to be part of our PPI group, and we still want members to be part of our PPI group, you don't have to live in that location. You can live nationally and still apply to be part of our PPI group. Again, I've touched on this. We're building a national coalition. This is where we sit. This is a broad program of packages within our GAIN program, and you've heard Antonio speak to some of those on work package 3C, and you've heard about the work of Mendelian as well. Essentially, what we're trying to do is make sure that we engender public trust in what we're trying to do and roll out AI tools, and that's essentially what we're trying to do. Set some framework which have patients as part of that engendering trust. This is just part of our governance program. And one of the things I thought we'd touch upon as we moved into talking with patients was around some of these key themes. And I'll touch upon that a little later as well. Now, we've already touched upon this in terms of Nobel Prizes, and it's really fortunate that the Nobel Committee awarded these prizes in the same week as the Symposium. Let's see if this happens next year around as well. But the key point around AlphaFold is that there are a number of iterations of that. The last iteration, I think, AlphaFold 3, also looks at nucleic acids as well and how they fold. And there's a variant of AlphaFold as well, called alpha missense, which looks at genetic variants, genetic mutations, and looking at the pathogenicity of those, which is quite difficult. A typical patient pathway, if you like. I'm trying to layer on some of the AI tools that are around there. This is just it's by no means comprehensive, and a lot of the work around there that isn't noted is around what Mendelian is doing and that GP, and you've heard a lot about what we're doing in CogStack in that hospital environment. But I just want to touch upon a few of those areas. Firstly, around symptoms. There's a study by the Kaiser Foundation, Family Foundation in the US, that found that 1 in 6 adults are using AI to look up their healthcare condition every month. And if you're under 30, that's 1 in 4. Yet we have no evidence, no research what the consequences of that are, if that's good or bad. If you look at the genomic testing pipeline, again, understanding that we've got a DNA sample, then sequences generate that sequence, usually millions of reads. That's bioinformatically stitched together into a sequence, and we have where we struggle with actually is the latter part. The former part isn't that difficult, but the latter part is, and there's a number of AI tools coming out that help us trying to unravel that, particularly that latter part. So, coming back to our patients. So when we started engaging our patient communities, that's really patient advocacy groups, patient charities. We started off with a number of questions to start the conversation going. And the themes coming back, which may not surprise you, is around responsibility and accountability, around data protection and accuracy, and issues like communications, what informed consent means. And one of the big issues coming out was, okay, you're going to help us screen our diseases, but you're telling us the NHS is broken. You won't be able to get us into the clinical pathways. So why are we doing this? And there was issues around what is the role of the doctor when we bring in AI? Is it either augmenting or is it replacing them? So having had that context and having spoken to almost 100 patients around different advocacy groups, I want to now bring our panel into this because we've got a really good panel around that. And I want to pick up, and if you have any questions, please put that into the chat. Now, I want to bring out our panel so we can either discuss some of the themes that are coming through, but also themes that they've also on their journey come up with. And this is a panel of 3 patients and 1 academic health researcher who's worked with a lot of PPI groups. So if I can begin with you, Liz, actually.
Do you think this is working?
It is working.
Okay, great. So you've asked me to introduce myself. So hi everyone, I'm Liz. I'm a reader in health data science from Brighton and Sussex Medical School. I started back in 2011 as an epidemiologist with a mental health background, using primary care electronic health records as research data, and have worked in the last 13 years largely around how we can identify and then use data and machine learning to address health inequalities and access to equitable care. For example, risk prediction tools and early detection models, and trying to find people who otherwise aren't accessing diagnoses in a timely way. I started working in public engagement around 2015, 2016, when the shutters came down on GP free text clinical notes. Prior to that, we had some access to those. And that was in the wake of, scandal, care.data, etc. And for me, that was a big data quality issue, as we heard from James in the last session. So much important rich clinical information is in the free text. And so I've been working with the healthcare text analytics community across the UK for the last 8 years on engagement around what patients and public think about sharing clinical free text, on health data sharing and linkage more generally. Recently working with people living with HIV, and we have quite a large population in Brighton, on whether they think HIV status should be shared in these databases, and plus some ethical sort of reviews and conceptualizations around using AI to analyse social media data for health research, and more recently what the ethical issues are around using AI to detect dementia.
Can we pick up on that dementia issue in terms of informed consent?
Yeah.
What does informed consent mean in terms of the dementia background?
So you've got 2 issues in dementia for using AI in, say, early detection of dementia or treatment of patients with dementia. 2 issues of consent. One is, can the patient consent, their capacity to consent, and if they don't, who has the right to consent on their behalf? And secondly, I think, as with any application of AI in health, you've got the issue of patient autonomy. Do they have a right not to have AI used in their care.
And you're dealing with conditions that, you say, don't have a treatment pathway as such. Does that cause concerns for the family around them if they're inherited?
Yes, so dementia as a genetic condition. So we know that there are some genes that give, if you're positive for those alleles, then you're very high risk of developing Alzheimer's early. And of course, that gives a real quandary in terms of who should know, who should you tell. I mean, I have a friend whose father developed Huntington's disease, which tends to progress to dementia when he was in his 70s. She'd already had children by that point, and it's an inherited condition. And she's really struggled with whether she should be tested and know about her risk of developing Huntington's, because she's already had her children, and then she's got to deal with their risk as well.
Okay. If you could pass the mic to Tony.
Hi, I'm Tony Quarterman. I became a trustee of, after 35 years now, I'm in a lecture at Brighton University. I became a trustee of Behçet's UK. Behçet's is an autoimmune auto-inflammatory disease which is no known cause, no known cure, affects any organ in the body, is only treatable with off-label drugs, and all those react differently in everyone. So this is a complete nightmare. And the only way of really addressing it is to look at the whole thing systemically. And at the start in 2017-18, I got out and about a lot, and particularly locked into EURORDIS, the European Organisation for Rare Diseases. We were basically trying to get a grip of 300 million people in Europe with rare diseases. Something like 30 million people in Europe. There's about 300 million in the world, and an estimate of 3.5 million in England. So collectively, they're not rare. And interestingly, in a study called Share and Project Our Health Data in January 2020, rare disease patients, regardless of the severity of their disease and their socio-demographic profile, are clearly willing to share the data. And the statistics are really stark. 97% would be ready to share their data to better understand the mechanism and causes of their disease. 97% to develop new treatments for the disease. 97% to improve diagnosis of the disease, or to improve their healthcare. 95% to receive additional specialist advice for their care. 95% are also willing to share their data to improve research on disease other than theirs. And it's interesting that rare disease patients seem more inclined to share the data than the general population. Depending on the study, between 37 to 80% of the general population declare they would be ready to share health data. And it's really important, this, because when I refer to some other studies later on, one of the issues at the moment with the National Genomics Test Directory is that people won't be testing unless there's a care path. You talk to any rare disease patient, what they want is a label. It's psychologically really difficult when you're bouncing around everybody, not knowing, sometimes people not listening to you, other times really looked after well, and not knowing what you're dealing with. And when they get a label, they then mentally can start to address what's going on. So I then attended, because back in 1978 or 80, Japanese Chaperone discovered a gene called HLA-B51, which was associated with Behçet's. And the reality is only 30% of patients have it, and those that are positive, and those that don't have it don't have Behçet's. And interestingly, I then started getting involved in the Genomic Medicine Service Alliance at the back of the 100,000 programme. Then I was asked to become the chair of the PPIE for Central and South. And the HLA region is really difficult to see stuff. There's things I don't understand called linkage disequilibrium and recombination, and basically all the way down to the generation of stuff is being passed down and then spread across the genome. So again, it's really important to look at that systemically. And at the moment, people who short-range sequencing, West studies, you need to do long-range sequencing and probably AI, I suspect, to start looking right across the genome. So that's the first area which it flagged up to me, where AI is needed in this sort of space.
Now, you've been involved in a lot of those conversations that we've had with patient advocacy groups. Do you think that there's been a balanced appreciation from the patient groups in terms of the benefits and risks of using AI?
Yes, we're very fortunate. We've had lots of well-informed, there's 100 people who mentioned it in those 10 different sort of cohorts. The only thing I would say is that they are of the more educated, well-informed part of the population. And what we've got to do as part of this study is get all the unserved communities, and we've got to do that through trusted leaders, through clubs, whatever, sports hubs and stuff, to get the message out. And I pick up a thing that Theo said, you know, I was keen to have one of these back in March before the programme really kicked off properly, rather than the back end of all the other work packages, because what you've all been doing with CogStack now is saving lives, it's helping people now. And that positive message needs to get out, because there's lots of disinformation. I mean, people talk about the cloud. What a ridiculous name. It's a load of databases. AI's got all kinds of different interpretations. So you've got to be really clear with patients what you're talking about, and then stop all the sort of hype and the sort of anti stuff that surrounds it.
Okay, we could move on to Alan.
Hello, my name's Quarterman, and I'm going to have to read this because I presented it last night and I lost my way about 5 times in the morning. So I'm a basically public involvement person representing you. It's called PPI, if you've not heard of it before. And I wasn't voted in the job, I didn't have an interview for it. I came to it via a diagnosis. In January 2007, I was told by Professor Murphy I had bone marrow cancer. I was at the end of the week in the thyroid clinic. He told me it was a good cancer to get. My mind was not listening. I put all my affairs in order. My mother had died within 6 weeks of diagnosis of cancer. So I just switched off and was running around in my brain. The professor did a wonderful thing then. He took me out to the waiting room. He asked one of the patients to stay behind as his nurse hadn't turned up that day. This lady called Penny started talking about her problems and irritations of living with chronic myeloid leukemia, CML. I interrupted her. How long have you had CML? She said, 8 years. I started to relax. I just won the lottery of life. I love this lady. I relaxed. Her patient voice beat that of the professor's. The thing about it is, I like fixing things. And I was a telegraphy engineer for 30 years fixing electromechanical devices. And from that moment on, I thought I'd like to fix things for patients. So I'd like to do MAD. That's the acronym I've got, you know. It's make a difference for people. MAD. And we can't all be Mandelas, but perhaps we can make a little bit of difference. And many of you here might go home at night and think you help someone, perhaps. I thought I'd like to do that. I'd like to go home and be much less of a tired waste of space. So I took up the opportunity to become a patient representative. I became a founding member of something called the South East London Cancer Research Panel, and the NHI sent me on courses to see how they're found, presenting to people. I just don't get a bit nervous and things. So, and they taught me how to chair meetings and things. I'm still not good at it. So, but we at the South East London Cancer Research Panel, researchers present to us, and we hope we make their research better by suggesting things and including the patient. Our voice is being heard in research. Now, who would have thought getting cancer was a career move? Oh, there we are. There's, I was going to show you here. I volunteer for everything. There's me on the cover of a booklet on my cancer, Macmillan. Well, now I've probably lost my way again now. I was one of the reasons I'm here, I think, is because I was asked by KCL to join a team with a top surgeon, a top health professional. We were tasked to see if an AI algorithm could match cancer trials to cancer patients as well or better than the King's Hospital doctors. My task was to be the voice of the patient. We were working via the internet, a meeting every week and then every 2 weeks for 18 months. And how do you put empathy in an algorithm? And look, there's no booklets, there's nothing on YouTube. So all I was doing, I was sitting in the meetings, there was 3 of us from the sort of NHS side, and I was just typing out every time I thought, how was that going to affect the patient at every opportunity? And one time I asked, could Debs, our surgeon, interrogate the algorithm to see how it came to its suggestion? The resulting meeting took an extra hour, and I thought, oh my gosh, I'm never going to get away to do some real work. Data, as we've heard today, is like a wonderful source of research, it's told us. Data belongs to the hospital, but it also belongs to you. It's your personal data. They can't phone you up every time they want to use a little bit of it and research. So I do a couple of other jobs. I sit on the KERRI, this is King's Electronic Research Records Research Initiative, and also advising St Thomas's cohorts. These panels decide if the research project should be given access to patient data, your data. So if you like, we can't ask every patient to come along and look at this research. I take it very seriously that I'm a bit of a gatekeeper, and if I don't think it's going to help or it's a bit of a waste of time, I take my role very seriously. I happen to be dyslexic. I think I represent every other dyslexic idiots like me that are shy, and I'm not shy. So as you can see, I'm sitting here. What we need is all types of people to volunteer so that they represent the whole of the UK in this frontier sort of revolution, so that we're involved. It's a democratic process. No decision about me without me. Put your hand up and get involved and say, I'm a patient, I'm also a member of the public. I want to safeguard the community.
Alan, can I just... Can I just ask a question on that encounter with your clinician, Ghulam Mufti, when he asked a patient to stay behind? Instead of asking a patient to stay behind, what if it said, here's an AI tool that'll show you what the consequences of your cancer are? Would you have used it? Would you have trusted it?
I think I would, because to start with, someone who's a professor, I will immediately stand up a bit straighter and salute. Basically, and someone's dyslexic with reading disabilities, you know, sort of not reading a book till I was 13. And so, I didn't find out till I was 50, but I respect education a lot, and I wanted it for my children and myself as well in later life. So I think this is the future, the AI. It's just a tool. We were working on a tool to narrow down 3 choices for the surgeon. The surgeon still had the choices, and it's going to help. It's not going to, you know, it's not his own. It's a mechanical thing making a decision on a human thing. It is a tool, any tool that makes life better.
Right, thanks. Hand to Zainab.
Thank you. Hi, I'm Zainab. So I wear 2 hats, both kind of the professional and the personal one. So professionally, like my background in health policy, I used to work for NHS England, looking at after like their innovation research and life sciences portfolio. So a lot of the programs that were mentioned today, kind of I had some role in at some point. And then I was doing my master's in health policy, and I decided to dedicate my master's thesis to really looking at AI and the adoption of AI, but specifically looking at like patient and public perception from a demographic lens. So whether people from certain demographic backgrounds had different perceptions of AI, and we found that race and ethnicity, and surprisingly, people from African and Caribbean and also Asian background had the most negative perception of AI. So that took me on to start the Hartman Fellowship, which is kind of a fellowship in policy and practice. And I went over to Stanford to do some research just generally about community-centered AI, so understanding more about why it is that people from certain backgrounds have more negative perceptions, and what can we do to really try and make sure that we have diverse engagement, because we know that AI is only as good as the data is fed into it, and if we don't have representation, then we have bias and all that kind of stuff. So I basically lead a kind of an international initiative that really tries to now understand kind of what the hopes and fears are about AI in different communities, and then try and make sure that we bring all those stakeholders together, whether you're a policymaker, a researcher, industry leader, a provider, to really understand and respond to those perspectives and make sure that AI is advancing equity rather than making things worse. So that's kind of like my professional hat. But I also live with sickle cell, and sickle cell, for those that don't know, it is a condition that predominantly affects people of African ancestry, and therefore it is hugely underserved. We have, 2 drugs available for sickle cell, and so we need some huge innovation and research in this space. So I do a couple of roles. Generally, I'm vice chair of the Sickle Cell Society here in the UK. I also co-chair the Genomics England Diverse Data Initiative, and together what we're trying to do basically is do whole genome sequencing for every person with sickle cell to really try and create this rich genetic database, so we could learn more about kind of the phenotypes, why people have certain like severities, and what we can do actually to try and improve lives with sickle cell. I also do a lot of work with NHS England about transforming patient care across the pipeline.
Yeah, just picking on that as well, because you wear a number of hats there. From I guess a policy perspective, do you think AI can either help or hinder those marginalised communities?
I think both. So I think, like I said, like it's a tool, right? Like, and actually we know that if it is used by a system that already has disparities, then actually what it could do is continue to amplify those disparities, but also has some huge potential to make things better. So there we know, like for example, AI algorithms that try and detect skin cancer, if they're only trained using white skin, then of course they're not going to be able to detect skin cancer in darker skin tones. So we know that's a problem, that we could increase health inequality that way, but we could also know that it can decrease health inequality if we are actually using AI to, for example, do remote monitoring and understand more about risk stratification of populations. So it could go either way.
I know you have a hard stop, you need to go early. So if I can just pick up another question on you. I know you've had some experience trying to reach out to those difficult to reach marginalised communities. What should we do? How should we reach out, particularly in using AI?
So I think one of the biggest things is actually like education and literacy. There's a huge trust issue at the moment, and it is not an unfounded kind of challenge. Like we know for historically, there's been like certain communities have been tested on, for example, and all this kind of stuff. So part of it is actually like going to communities and telling them why it's important. A lot of the work that I do, like I get to meet so many different community members and community leaders, and there's actually an active campaign to make sure that people from their communities don't engage in this stuff. Like there are community leaders out there telling people, don't do this, don't say yes to sharing your data, don't get involved in genomic medicine trials, don't get involved in any AI kind of activity that they want you to get involved in, because it's not for our own benefit. We see it in, for example, the criminal justice system, how AI is actually being used to over-criminalise certain communities. So like they're not like unfounded challenges. So I think part of what we need to do next is actually just going out to communities and telling them that AI is here whether we like it or not. And
you not being in the data is just as dangerous as you being part of it. So it's about being able to teach people about what's good and what's not good, and then good practice and bad practice, so they can advocate for themselves and advocate for the community going forward.
Okay, great, thanks. So you have an audience here of developers, academic researchers, clinicians. What would your advice to be from a patient perspective in terms of delivering, rolling out AI tools? It's a broad question at all.
Advice is actually making sure that you have patients at the table very early on in the discussions. Too often you see patients being involved or members of the public being involved right at the end, when you've already created, you've invested so much money, some time and effort, that even if you hear feedback, sometimes it's like, well, you know what, we're not going to change that because that's just going to cost us way too much. And so actually involve them early, so you're making sure that you're innovating for the problems that actually will help them, and you know what the barriers are as well, so that you are you're making it as accessible as possible. So I'd say often and early, and also just in a meaningful way. So too often, again, people are engaging patients, but you're not valuing their contribution because you've got these incredible papers, but you're not including patient names, you're not reimbursing them for time and effort and energy. You are not giving them the skills and the development. So it's incredible to hear that Alan was going through training to do his patient involvement role. Too often we put patients in those roles and in rooms where everything goes over their head because they're not trained to the level that they're able to really engage in a meaningful way.
From Alan next.
That's really good, Zainab. You mentioned everyone's got to be involved. And getting in early, I've got a little story here. I said I work for South East London Cancer Research Panel. Don't like it when I say sell crap, you know. But we had an anaesthetist come in, and she was on Zoom talking to us, and she said she was putting parabolic block, a radioactive block, in patients after they'd had a lung removed. And this was to kill pain for the patient. So he thought, I wonder what would happen if I put one in a few days beforehand, because these dissolve, these parabolic blocks, and the patient doesn't know. So she tried this. She put one in one patient. She asked him if it was okay. He said, okay. She put it in, had his lung removed. He went home 3 days early. She thought, well, this is a good idea. So she told another anaesthetist. I don't know whether you know, anaesthetists tend to all be female in the NHS because you don't have to mess with messy patients, you know. They're all asleep when you deal with them. I'm sure that's it, you know. Anyway, and she presented this research to us, and it came through on a Sunday night, and I happened to be up. So I sent straight back a reply in an email. This is a no-brainer. This is good for the patient, good for the NHS. You get a bed vacant, and the patient goes unhappy, less pain. It's a win-win situation. And then 3 months later, the research came back to our little group, and I said, I've already looked at this. I saw this. Why is this? She left it too late, and she was going to get the money for the research on the Thursday, and I was the only person who got back to them that night, and that wasn't enough PPI input. So when you cannot get money now since 2010 research unless, if you're doing research, unless you've got patient involvement. This is part of the democratic process, getting patients involved in research. So do think about it early. In just an idea research you can present to somebody. Doesn't cost anything, and sometimes you're going to get even a little bit of money towards asking patients things about research that doesn't even exist yet. You know, this is how we're geared up in this country. So use these facilities, get patients involved. That's a party political broadcast.
Yeah.
My message, if I'd gone first, I would have said exactly what Zainab and Alan said. But to add to what they said, there's this big issue of trust and trustworthiness. The research I looked at suggests that people have trust in two things. One is people's competence with data and data security and privacy. They want to feel like you're a competent handler of their data and protecting their privacy. But more importantly, they trust or distrust motivations for using the data. And one of the things again and again is they're very worried about a profit motivation in use of the data. But of course, as we've heard, you know, a lot of these technological innovations are partnerships with industry, and they kind of have to be because of the agility of industry compared to academia. And so this is something where we possibly need to work harder to explain the reasoning and bring patients on board. And again, right from the beginning, you know, why are we partnering with industry? Do they have a profit motivation? Does this mean my data is going to be sold off to some big faceless organisation? You know, we need to be reassuring patients that the motivation for developing these technologies is to improve benefit their health. And so with that in mind, I would also ask you to think about, well, what does your AI do? And where is the pathway by which it is going to improve people's health outcomes? It's no good just making a risk prediction and then nothing happens. You need to be working with people out on the ground to develop that clinical package, pathway or intervention for those high-risk people that changes their trajectory and improves their health.
And I'd add to that, sort of clarify, just diffuse the mystique. You know, I mentioned that iCloud. What specifically we're talking about using AI, and the final one I put down is step on misinformation as a collective, because that's really disruptive. And I lived for nearly 8 years with an army program where I was permanently waiting for another reporter to try and rubbish the program that I'd been involved in. And it's really important to stop rumour and speculation at the start and correct things to make sure that factually people are well informed.
Okay. Before I hand over to the audience for some questions, just act on an optimistic note. So, if you had your personal AI agent, AI bot, and some of you had life-changing diseases, what would you want it to do?
Tell you what they are doing for me right now,
Yep.
which is quite helpful. So I'm about to have a stem cell transplant, and if you guys don't know, it's actually a really intense and quite bit of a scary process, but also it's mainly used for people with blood cancers, or in the past anyway. So when I was trying to find out information about it, went onto TikTok, Instagram, everything that I could find just to try and find patient stories, and I just really couldn't find that many patients that had sickle cell and going to blood transplant. So I went to Gemini and I was just asking Gemini some questions, and actually did an incredible job of being able just to explain what having a transplant for sickle cell will look like for me, and very, very tailored based on kind of prompts that I was giving it. So I had a nice chat with generative AI, and that was really helpful.
So I actually live with a chronic illness called fibromyalgia, which is a really rubbish illness because there's not really any treatment for it, and it involves widespread chronic pain. And my best understanding is it's kind of associated with a bit of a frazzled nervous system, and there's quite a lot of symptoms from dysregulated autonomic nervous system, for which there are different treatments. So I would like AI to build for me as a personalised view of what different medications would be useful for me to try to sort of modify my nervous system as it's gone awry.
So this is the personalised AI to help you out. I met my wife through the internet, and that was in 2001. So it's a long while ago. We only got married this year, so I passed the probation here. But if it was AI that introduced me, it doesn't matter where you meet someone for, you know, you want to be the life partner. It's the partner that counts, not the road you took to get to it. AI is a tool to help us get to the road, and if it can get to us quicker before your child dies, or you know, just time is important. That's all we've got that's important. Our lives are time. So we want something that will work fast and hopefully pick out the diseases and problems for the future generations. We are going to get inoculation against cancer, you know, and vaccinated. So we've got to trust AI. It's made by us for us. So I don't see the problem. The problem could be if the paper finds it makes a mistake and then blows it up, and it gets put out there that they're trying to kill us. They being, I don't know who, you know, but the NHS is working for us. They are all new people looking after all new people, and we've got to give them the tools to help us.
Just a nuance on that, Alan, that if the AI bot arrangement was provided by a commercial concern rather than the NHS, would you have same optimism about using it?
Yeah. See, my cancer was discovered what was causing it in the bone marrow in 1986. So Big Pharma has had all those years to work on finding cures for it. They haven't found a cure yet. I had my chemotherapy every morning in the shape of a pill. And when I had some trouble this year, the kidney trauma due to some other medication, but I've got comorbidities all over the place. My cancer doubled and trebled, and it was 336% bigger, the amount of cancer I had in me, by, you know, because they stopped my cancer drugs because it affected the kidney. So they put me on a new super duper one, my fourth cancer pill. The NHS hasn't got the money to invest in drugs trials. A lot of them are blind alleys. Big companies working, spending millions on it. They want a return for their money. It's all to do with money. We can't do it. We've got to go into partnership. And one of the groups I sit on, Guys and St Thomas's cohorts, we don't actually sell a patient data. There is a whole department in Guys that sells it, but we go into contracts with them. If they find a cure due to our data, then they share it with us, and we share some of the profit. It goes back to patients, and we have to work out deals with people. We can't shut out this wonderful big pharma. We can't deal with it ourselves. We can't make machines even, you know. So we have to use, you know, machines for X-raying people. The NHS doesn't make them. That's just partnerships with companies, and we've got to go in partnership with everybody.
Thanks, Alan. Don't you have a feeling on that?
I think this would be asked. I think the assistant in the diagnostic odyssey process, it was mentioned, assist with the drug regimes, with medication process, pharmacogenomics. I think there'd be a lot of benefit there. And then learning lessons from other patient experience, really, all based on evidence, large data numbers, potentially better informed than current research studies are actually done, and then done internationally.
Okay. So let's go to questions. Do we have any? Okay.
First, thanks very much to all the panels. Really interested to hear you guys' experience with this. We've heard a lot today about data transformation and the nature of the healthcare system data that exists currently, and obviously the huge steps that need to be taken in order to mobilise this data into something that can actually benefit patients. The question is kind of two-part. Firstly, do we think the public are currently in a position where we have a sense to go forward with the necessary steps? And secondly, do we think the argument, if we aren't ready for that, would be won by having conversations and learning, or by demonstrating the benefit first and then coming back to the learning literacy element?
Did you have to take that?
Okay. So the second question was around what should we do first to gain trust? And the first question was around do we think the public are on board? So generally surveys, focus groups, etc., have found that largely around 80% of the public will express their support for data to be used from their health records, as long as it is anonymised or, de-identified, at least kept safe, their privacy secured. So in general, a lot of members of the public are in favour. And in fact, some members of the public are scandalised by the lack of data joining up in usage, and then in general want to see their data being used to improve the efficiency of use of resources, to improve their care, to join up the care between specialties, etc., etc. So I think overall, from the research that's been done with the public, we have a mandate to use data. In terms of taking, what could be considered quite high privacy risk data in terms of unstructured data and using it, where members of the public were informed about that whole process, then they supported and approved that use. So I think I constantly hear we want to know what the clinical benefits will be of our data being used in that way. So I definitely think we need to think of this as a loop that goes round, where we're putting just as much energy in informing patients of what has been done with their data as we are in trying to persuade them that we should be able to use it in the first place. But do you want to answer that?
I think it also depends, right? So we did a study a couple of years ago, and the public was saying actually it depends what kind of data. So, for example, qualitative data about how they're feeling today, like pain scores, that kind of stuff is very different from the genomic data, for example. So it really depends on the kind of data and the sensitivity of that data, but also the population as well. Like we spoke about earlier, certain demographics will have more, will be more wary about sharing more data than others. So trying to really understand why and some of the challenges. So in the US, we found that African American populations were really skeptical about wearable devices. So Apple Watches, Fitbit, because to them it reminded them of ankle monitors and criminalisation and all that kind of stuff. So I think it's about I don't think it's a one size fits all thing. I think it really depends on the kind of patient. I am very sorry. I can't with that.
No, thank you to Panel. I know you've had a terrific journey, haven't you? Any more questions from the audience?
Able to identify them, and I don't think people have grappled enough with the fact the techniques we previously used to anonymize data aren't as robust anymore. Just a few months ago, a paper was published where it was proven just from Wi-Fi signals you can detect how a person was thinking and what actions they were doing. So you tell people it's anonymized, but is it really?
If I just rephrase the question, because I don't think that question is probably appropriate for this point, but it might be.
Can answer that. I'm really interested. I'm just writing a paper on this now. I'm very interested in this topic. So, especially free text data, how can you know that even if you run an algorithm to the identifiers won't slip through, people won't match in data. Almost all data in this country is hosted in a secure data environment. And it should be considered that though the protections of the secure environment, so people have to be accredited, screened, trained, and then they log in, they cannot match in other data, and they sign a user access agreement that says they will not re-identify anybody. Those are the protections that the anonymity rests on rather than the strength of the de-identification. You guys want to add to that?
Obviously, you want your data shared, from the hospital to your doctor. They're trustworthy people, and this is what's going to happen. Again, sort of a knife, you use it every day to cut up food. If a bad actor gets hold of a knife and goes around killing people, we don't ban all the knives. Basically, this is a tool, and it just makes life a little bit easier for all of us, and hopefully saves lives. Just because somebody uses it for warfare, as we're seeing now in the Middle East, does not mean to say that we've got to blank out all AI. This is AI for medicine, which is helping people.
Last question, too.
So just a rather disruptive question. There's obviously a huge free rider problem here, in that those who don't contribute data may still expect to benefit from the research. Does the panel think that we should strive to eliminate the free rider incentives?
No, not at all. It happens everywhere. You know, if I think how hard I work in retirement times whilst you still have cancer, you know, the only reason I'm on the planet now is to do good for other people. If I compare myself and try to be judgmental, one, it's not really Christian, it's happened to be. The disadvantage will be, I think, it'll be interesting in the generation study. I've brought along with there's a 200-page report that the Panellists study, which is done as a precursor to what is now called the newborn programme. And we had a brief yesterday on it, on our unified board up in Central and South, and of 690 people, 70 people rather, 407 have signed up to it, 269 haven't, so it's about half haven't at the moment. Now, I think as success carries on, that would be fine. Just because, you know, a parent doesn't, you know, want to sign up for various reasons sort of thing, then you cannot disadvantage them. My worry is that when they realise a few years later that they might have been able to help the child, they might feel a bit guilty, but it's life. So, you know, you can't be.
I don't think we're, you know, if I'm a Labour person and we've got a Labour government, we should destroy all the, or ignore all the Tories now, you know, we're in power because they didn't join in. This is a tool for everybody, you know, and you can't just keep people out of it. So.
Yeah, and also why are people not joining? Why are they scared of joining in? I think they've probably got legitimate reasons that we need to really think about as a community and address and reach out and listen to them.
Okay, I think it's time to.
What happens when something goes wrong in AI employed? Like, is there an audit process or is there standardization around that?
So what happens if one goes wrong? Is there an audit process?
This is an ethical issue. Who's responsible for an AI decision that harms a patient? Who's going to take responsibility? And this is one of the key issues with deployment of AI is you're asking the doctor to take responsibility because the AI company is very unlikely to. And a lot of clinicians don't want, if the AI is not explainable, they don't understand what's working, they don't want to take responsibility. But then, you know, is it a tool that they can use as part of their clinical decision making? Again, that comes up with trust. Do they trust it to be accurate and helpful?
And I just add, there are obviously international standards now to do with it being developed, and I would encourage any of you researchers to get involved in that, read it. If you've got any comments to do with it, either the British standards or the international ISO standards, make some comments, contribute to it.
And the more people involved in AI, the more it will represent you. You can't sit out on the side like James suggested, the freeloaders, you know, and then come in when they're giving away something free, like the rest of your life, like with a treatment that came in through AI. So you've got to be involved in the community, basically. If you're giving blood to people and then you get ill, and someone else gives blood to you, you feel you're part of the community. It's part of being human. We look after people, and people run into fires and rescue people. It's just that we basically, most of us are trustworthy. We don't sort of say, oh, I did vote for him, so I'm not running near that building to rescue.
Okay, thanks. I think it's best to bring that bit to a close. So can I ask you to give your very warm appreciation to our panelists? Okay. This leads me to wrap up as well with some reflections. And I'm conscious that I'm in the way of the refreshments that are in the atrium. Firstly, thanks to our sponsors, Beijing and Boston, without whose support, we wouldn't have been able to lay this on and make it as inclusive as we've had. Yeah, please do try and complete the feedback forms. They'll be emailed to you after this session. We want to understand if there are any missing themes that you want us to explore in future symposiums. So do please take the time to fill those forms in. When we were trying to set this symposium up, we were debating on whether it should be online or hybrid. And I'm glad it was hybrid because there's value added in bringing everyone together and having those conversations you probably had in the atrium. They're usually very rewarding. So I hope we keep that format going forward. It was an unusual conference as well in terms of that. It's unusual in a symposium to have that breadth from, if you like, research to bedside. And for some of the presenters, it may have proved challenging to present their research to a broad audience, but I think it was rewarding in the end. Some of the key themes that were coming out of those for me was actually from the first theme around what we're doing. Actually, we can do it on a system-wide scale. We've done it in South East London. There are still milestones to go, and we can do it in other places, so it can be done. Whether we can do it at a more regional or national basis, that may need support. Secondly, in the industry forum, this is a problem everywhere, I think, in terms of access to data. We've had those problems as well. I think if we're going to get industry to be a significant partner going forward, we've got to help them solve those access issues, those governance issues, those ethical issues. I think that's important. I think from the third theme around medicine, it was actually interesting to see the different ways that we're using it, some very successfully at a population level, at a subpopulation level, and a cohort level with cardiomyopathy. So it's really good to understand how we're actually using it and using it at scale. And the last bit, the patient bit, I have to say, when I got involved in the PPI group, I did it with some intrepidation because I hadn't dealt with patients at that level. And gosh, I found it really rewarding. Some of them actually are really well, well, actually the most part, they're really well informed and they want to get involved. So my challenge to all the other groups, the researchers, the clinicians, yeah, get them involved as early as possible. Okay, so drinks out there in the atrium. Enjoy yourself and thank you.